Hello, good evening, and welcome to this Lucio webinar on highlights in lung cancer research. Today, it is my pleasure to introduce you to our speaker, Dr. Benjamin Besse, Professor of Medical Oncology at Paris-Saclay University in Orsay, France, and lung cancer specialist at the Gustave Roussy Cancer Campus in Villejuif. Sorry, my French is not good, so thank you very much for your time. I would like to thank you for your valuable time today on behalf of Lung Cancer Europe, Dr. Besse, for being with us today, sharing your knowledge in this important topic. So, as part of our strategic objectives, Luce is conducting a series of educational webinar for you, for patients, for caregivers, advocates, and so on. And today's session, the primary aim of today's session is to provide you with the latest updates on the developments and research trends in lung cancer, trying to enhance your understanding about both the current and the emerging therapies for this disease. So for those of you who are joining a Lucha webinar for the first time, the session will basically be split into different parts. So first of all, Dr. Besse will present a review of the current management of lung cancer, highlighting mainly the new studies, and this presentation will last between 30 to 40 minutes. And then you will be able to ask your questions in two different ways. So the first option is by clicking on the participate button, the one with the hand icon at the top of the Microsoft Teams application that you downloaded to join the webinar. And if that's okay, I will unmute you and your microphone, so you will be able to make your question live. If you alternatively prefer to send your questions in writing, just use the chat of the Q&A window, and I will pass them to our speaker right at the end of the webinar. So with that being said, I wish you all a very fruitful session, and without further ado, Dr. Besse, the floor is yours for the presentation. Thank you very much.
Thank you very much. And I'm very honored to be here. It's always a pleasure to speak to such a large audience, in particular with patients. Okay, so during the next 40 minutes, I will give an highlight on lung cancer research, and I will obviously focus on clinical research and research for patients. I'm a medical oncologist. I work at Gustave Roussy, which is a cancer center in Paris, and there I manage only thoracic malignancy, and I'm head of clinical research. I will show my disclosures. Everything goes to institution. What we have learned since 20 years, I have started my clinic in 2005 with my first lung cancer patients. And at that time, lung cancer was almost one disease. Well, there were a few different types of cancer, small cell and in non-small cell, the squamous and adenos. But at that time, only one chemotherapy was there, or let's say two at the most. What we have discovered in 20 years is that lung cancer is not one disease, it's a number of diseases. And each subgroup of lung cancer can be very, very small, very, very tight. It's impressive because in this small subgroup, we can have active drug, but it's a real challenge for drug development. I will start with the first revolution we had, which is the oncogene addiction. The first gene that we were able to target is called EGFR, and the mutations in EGFR were discovered 20 years ago in 2004. And since then, a lot of additional abnormalities has been discovered with matched drug. Why we call that addiction? Well, you know what is an addiction. And we are talking about addiction because we believe that the cancer cells are addicted to a signal related to a gene that is mutated or as a fusion, well, an abnormality in the gene. So as I said, the first example was EGFR, and in the Caucasian population, 10% of the patients have a mutation in their non-small cell lung cancer, and it's EGFR. It's up to 50% in the Asian population. When there is an EGFR mutation, the cancer cells needs the EGFR signal to divide, and so the tumor can grow. And it needs the signal so bad that if you inhibit the signal, the cancer cells deprived of the signal can either stop their division or even die. And this is what we call that oncogene addiction. So our goal here is to find ways to inhibit these signals. And this is what I call the Achilles heel. When I explain that to my patients, I explain that I will look for mutations in their tumor to find the Achilles heel and then be able to give a specific drug. We have now 10 molecular entities in lung cancer, and as you can see, it can be up to 13% of the patients, but in some of the cases, like NTRK, it's 0.25% of patients with lung cancer. For these 10 molecular entities discovered since 20 years, we have now 26 targeted therapies. 50 to 70% of the Western or the Asian population can have such an addiction in the cancer cells. So it's really something that is growing very fast. The revolution started 20 years ago, as we said, but it's still a revolution ongoing because we find either new targets, either new generation of drug for the existing targets. As you can see in these guidelines that were published last year by the European Society of Medical Oncology, the complexity of the treatment increased a lot because there are so many subgroups of lung cancer that we have a lot of different management, because obviously a patient with a ROS1 positive non-small cell lung cancer will have specific drugs that will apply only to these 2% of the population. The other will not benefit from such drug. When we're dealing with such small group, we are then dealing with rare cancers. And this is something that is very difficult to understand when we are talking about lung cancer, because lung cancer is a very frequent disease, and it's not at all what people imagine of a rare cancer. But in fact, in the group of lung cancer, there are a lot of subgroups with molecular alterations that are so rare that, in fact, this subgroup, if we just look at this subgroup, it is considered as a rare cancer. I'll take the example of the RET fusion. It's 1.7% of non-small cell lung cancer. So the incidence will be 0.92 in 100,000 people. And this is exactly what we called a rare cancer, because the incidence must be less than 6 patients out of 100,000 individuals a year. So you see, we are really dealing with rare cancer, but among an entity that is really frequent, lung cancer. Because the molecular profile is so important, it's now part of our diagnosis scheme. When there is a probability of lung cancer, we obviously do all the workup with brain MRI, PET scan, CT scan, obviously a pathological confirmation, meaning usually a biopsy or a punction for a cytology. But then the next step, before deciding what is the therapeutic strategy, is to get the molecular profile and understand in which subgroup the cancer is or is not, obviously. The molecular profile can be done on tissue, but now it can be done also in liquid. And this is a huge need that we have it's the molecular screening, because when we diagnose lung cancer, we need to know what type of mutation is in the cancer. ESMO has published 2 years ago a very interesting study run in 53 countries of the European region. There, they have looked at the availability and accessibility to the molecular assessment in these countries. The arrows, well, this is 2 examples in lung and breast cancer, but let's focus on lung. The arrows is for at the time, for the abnormalities in which a drug was available in the market, meaning approved by EMEA. As you can see, when there is a drug on the market, usually there is a good access to the molecular screening. On the right side of the black arrow is the targets for which there is no indication, at least at that time, 2 years ago, there is no drug that is approved, but drug can be found either through a clinical trial or sometimes an early access program. And this is a pity because when the drug is not on the market, the screening is really poorly done, although these patients could benefit from a clinical trial or an early access. So molecular screening is currently one of the big issues we have to solve, and we need our patients to have a broader access to the molecular screening. Why there is an issue? Well, as you can see, in some countries, there is no health authorities in charge of the molecular screening. And in most of the country, there is no fixed reimbursement for this molecular screening, which is a huge issue for the patients and for the physician when they want to order this test. One thing that is clear is that the molecular testing was first done on the biopsy, but unfortunately, usually the biopsy in lung cancer are very small, or sometimes, even if they are big, you don't have enough tumor cells because, for example, you have a lot of necrosis, so you don't have a lot of tumor cells. And in fact, around 30% of non-small cell lung cancer are not able to be tested because there is not enough tissue or the quality of the tissue is not enough. And in this situation, what we call a liquid biopsy, which is in fact not a very good term because it's not a biopsy in terms of the tool that makes a diagnosis, but it's let's say a general wording for all the technology that can assess circulating markers that can be a surrogate to the molecular screening. What we can do now is analyze the circulating DNA of the tumor that you can find in the blood. In our patients, we know that there are very, very small fragments of tumor DNA that circulates, and by a very simple function, we can capture this tumor DNA and make an analysis. This slide done by my colleague Jordi Ramon shows you that when you compare the number of, let's say, positive tests in a blood liquid biopsy or in a tissue biopsy, in fact, the liquid biopsy is much better, and the turnaround time is usually better on liquid biopsy. Again, access to liquid biopsy is still an issue. In a lot of countries, the access is very limited, although this is a very interesting tool that helps you to analyze this gene, even if you don't have enough tissue left. Why do I have lung cancer? Well, maybe I have smoked, and this is the main risk factor, obviously, but in 15% roughly of the patients, the tobacco is not the cause of cancer. And when a never smoker has lung cancer, it really feels, why do I have that since I have never smoked? And this is a question we can really answer today. This alteration I was alluding to are mostly found in never smokers, and we don't know really why. What is the risk factor who induce this specific mutation? One of the main risk factors is the radon exposure. Radon is a gas that is radioactive that you can find more prominently in some areas of the world. And radon exposure increase the cause of lung, in particular in the never smoker, but also for the smokers. With Dr. Laura Mesquita, we are running a study called BioRadon. It's led by a European Organization of Cancer Treatment and Research, which is EORTC. And in this study, we give a radon detector to the patients to try to understand if radon is not what will induce specific mutation or fusions in the cells, this being, let's say, the first step to the cancer in the patients. And it's important because radon exposure can be prevented, and thus we can act on that. But here the study is really to understand what is the biology behind the radon exposure, and I hope that we will be able to tell someday a patient that has, for example, a ALK positive non-small cell lung cancer, this is why you got your cancer, and this is how we can prevent other people to have this cancer. Pollution is also a major challenge, although the exact pathogenesis of what pollution does on lung and how it creates lung cancer is not perfectly eluded, but definitively this is one of our major challenges. So the drug development in the field of oncogene addiction has been incredibly active. I will take the example of the second target that was found after EGFR. It's the ALK fusion. We got in the early 2010 ALK, the third generation of ALK inhibitor called crizotinib. And now we have 3 generations of inhibitors, and all are more active than chemotherapy or more active than the first generation inhibitor. We know that crizotinib, the first generation, is not probably the most potent inhibitor, and now the discussion is, should we choose a second generation or a third generation to treat our patients? Although when we give a second generation, at the time of progression, we can give a third generation. What I explain here is that we have this different generation of drugs. Probably the higher is the generation, the more potent is the inhibition. But in the life of a patient, is it better to give the best drug first, or should we sequence giving I would not say a soft inhibitor, but maybe a second generation inhibitor first line, and then move to the third generation third line. Very recently at ASCO, 1 month ago, we saw the update of the study of the third generation inhibitor called CROWN, and with a 5-year update, which is a very, very long time of follow-up of the patient. You can see that the patients that receive lorlatinib, the third generation inhibitor, as a first-line treatment, has very, very good control of the disease. This is the blue curves compared to those with the first generation crizotinib that we don't give anymore today. But still, this is a very long period of time. But what about those patients that receive crizotinib and then move to lorlatinib? Is it something that is deleterious for the patient, or is it something that can bring a benefit? Well, if we take a former example, that is always the first generation crizotinib, but this time compared to a second generation alectinib, you can see that on the survival curves, the patients that received the first generation inhibitor followed by alectinib had the same survival as the patients that receive alectinib first line. What it means is that patients that receive a sequence of first followed by second generation inhibitor had the same survival of those patients that started directly to the second generation. So for us, the physician, it's very important data because imagine there is a patient that listens to us and is currently treated with a second generation inhibitor. He might think, well, maybe my treatment is not optimal and I should receive right now the last generation, the third generation. Well, our answer is that today we don't know what is the best strategy. Access to drug is something that is very much an issue in lung cancer. I will give you an example of a very recent drug called selpercatinib. Selpercatinib is a drug that inhibits RET. RET fusions can be found in 1.7% of patients with lung cancer. When a RET fusion is identified, we know from very early data that selpercatinib can induce a response is more in 84% of the patients with a very, very good progression-free survival, meaning that it's highly potent and when it works for a long time. Based on this very early data, the FDA gave a very early approval in May 2020, and they asked the pharma company to generate more data with more patients. What they did, and 2 years after that, they got the full approval. EMEA in Europe, FDA in the US, sorry, EMEA in Europe had a different approach. They said, okay, this is interesting data. We will give a conditional approval, but we will need randomized data to be sure that what we see here is a reality. What means to randomize? It means to compare in a trial patients that will receive the standard of care treatment. At that time, it was just platinum-based chemotherapy to selpercatinib. So this is the way we can formally assess the efficacy of the drug. Our issue here is that on the data that we had at that time on the efficacy of chemotherapy, we knew that chemotherapy efficacy was not, and by far, not as good as this kind of figure where almost all patients have a degree of response to the drug and the duration of treatment is very long. But still, EMEA tells us, well, we are not sure that maybe this is a population that is highly sensitive of chemotherapy, and you need to show us randomized data. The issue is that even if EMA approved the drug, in a lot of European countries, the drug was not refunded because some health authorities, like in France, said, the drug is on the market, it's a conditional approval, but Europe wants additional data that is randomized data. So maybe there is a doubt, I will not refund the drug. And there is a huge issue in drug access to the patients. And obviously, we are talking about a very small niche, 1.7% of lung cancer. So for example, in Spain, in France, it's very few patients. So you cannot argue that it will be a huge financial burden for these countries because it's a very limited number of patients. Again, it's a rare cancer population. So this discrepancy in drug access is really a concern. And we have to find ways to assess the drugs in a different way so that we don't waste time doing studies that are not really needed. For selpercatinib, the study was done. Although it's a very rare population, the pharma company ran a trial, managed to randomize more than 300 patients between, 261 patients, and that were randomized. Either they receive a chemotherapy, plus or minus immunotherapy, either they receive the targeted therapy. As you can see on the curves, obviously, and this is the data we knew already, but it was not formally proven in a phase 3, selpercatinib is much more potent than that chemotherapy. So my take on that is that this kind of study are not needed. We need to find a new way to convince regulators and HTA that a study, what we call a single arm study, meaning without randomization, with outstanding results, may be enough to put the drug on the market and to refund the drug, such as FDA did. We have now a new generation of drug, and the history of addiction is really, I understand the cancer biology, and I build new drugs by this based on this understanding. At the time of chemo was just poison that you can find in flowers or in or a synthetic poison that you give to patients, and that is poison to patients, but more to the cancer cells. And it was not, but the poison was not specific to molecular alteration. With oncogene addiction, we find the gene, we find the Achilles heel, and then we design drug based on the biology. So it's really something different. Understand the biology, build the drug. I will take the example of EGFR again. So we have now 3 generations of EGFR inhibitors. Osimertinib, the last generation, is today standard of care when a patient is diagnosed with a metastatic lung cancer and an EGFR mutation. But after a few years, a few months, the cancer cells will understand how to grow despite the inhibition of EGFR. And there are many mechanisms of resistance that can be linked to EGFR or to something else. We call that on-target or off-target resistance. One of the main off-target resistance is, for EGFR, the amplification of a protein, of a gene, called MET. When MET is amplified, there is more MET protein on the cells, and this protein will give a signal of division to the cells, although EGFR is well inhibited by osimertinib. So MET is a way for the cancer cells to escape the inhibition of osimertinib. So how can we act on that? Well, we could combine MET inhibition to EGFR inhibition, and this is what we did. As an example, a bispecific antibody, which is a new generation of drug, was designed. It's an antibody that you inject in the blood of the patients, and this antibody will recognize EGFR and MET, and in a way will block both signals. The drug is called amivantamab, and in patients that were exposed to osimertinib, obviously patients with EGFR mutated non-small cell lung cancer, the study has compared a classical chemotherapy, a chemotherapy plus amivantamab, or a chemotherapy plus amivantamab, and a new EGFR inhibitor called lazertinib. What it shows is that when you add amivantamab on the chemotherapy, you increase the control of the disease. The study is clearly positive, and we hope that the drug will be on the market soon for all the patients that received osimertinib and at one point will experience disease progression because of resistance to osimertinib. So you see, we understand biology, and new drugs are designed based on this understanding. So now we have a lot of questions because obviously, maybe in a patient with a newly diagnosed lung cancer, it will be better to give directly amivantamab, or maybe to give a chemotherapy plus osimertinib. So now we have a lot of discussion of what is the optimal first-line treatment of patients with untreated lung cancer with EGFR mutation. Is it just the EGFR inhibitor, osimertinib, or should we escalate the treatment, adding a chemotherapy, or using amivantamab, this bispecific antibody? Well, based on the survival curves, it seems to be better to use an escalation strategy, but obviously it comes with a lot of side effects, and quality of life is key. So again, a lot of discussion with the sequence. Shall I start with osimertinib alone and then escalate to chemotherapy at the time of resistance? Or shall I start strong directly with chemotherapy or amivantamab combined with an EGFR inhibitor? Well, it's a good question because we have drugs. So when we have different drugs, we have this question, but you see, this is what we call the sequence. What is the best sequence for a patient? And at the end, it will be what is the best sequence for one patient, because probably EGFR mutation is not exactly the same, and there are different mutations, different patients, different immune systems. So at the end, we will have to understand what is the best strategy for this specific patients. So this is just an example to say that first line, we have different options. New category of drug that I would like very much to talk about today is what you call the antibody drugs conjugate. What is an antibody drug conjugate? It's an antibody. So the antibody is something we generate and that is able to recognize a specific pattern on the cancer cells. So we call that an antigen. So basically, imagine the cancer cells have a red cap. Well, we design an antibody able to recognize red caps, and then it will go directly to the cancer cells. The goal of ADCs is to link chemotherapy, what we call the payload, chemotherapy to this antibody. So the antibody will go in the blood, and the goal would be to bring directly the chemotherapy to the cancer cells. We can call that smart chemotherapy, vectorized chemotherapy, targeted chemotherapy. Well, the reality is that it can work. We know, for example, that at the time of progression on EGFR inhibitor, there is a protein called HER3 that is upregulated, meaning there is a lot of HER3 on the tumor cells and the cancer cells, sorry, in the surface. And then if we give an antibody drug conjugate against HER3, it's called patritumab deruxtecan, a lot of patients have a benefit to this treatment. So again, new generation of drug, I would say new generation of hope. There is an ongoing trial that randomizes as usual, but there it's very fair, standard chemotherapy to this new generation of drug. If the trial is positive, we will have a new option, meaning we will have to understand again, with this new drug, what is the best sequence between all the drugs we have. Just to give you an example that we are, I was talking about ALK. We have 3 generations of ALK, but there are new drugs that are coming. And this is a new ALK inhibitor called NVL-655. It's a drug that is promising. There is activity. There is activity even in patients that received previously the 3rd generation ALK. So it seems to be interesting. It's still on development. And sometimes, well, it's open in my institution, but in a lot of institutions, but sometimes it's not open in your country. And I have a question time to time that is, I'm a European patient. In my country, I don't have access to this drug because the trial is not open. Can I go to a different country in Europe and be treated? I'm really talking about patients living in EU. Well, it's possible. For example, if you ask me, can I join? I will have to first check that there is possibility to treat patients in this trial. You know, sometimes they're close to recruitment. So we need to, let's say, secure a slot. And then the patient need what we call the S2 form, which is a form that allows the National Health Insurance to communicate. So the patients need to ask his own oncology to get the S2 form to be able to be treated in a different European country. Then the patients come in my institution, or any European institution where the trial is open, obviously, and he must receive an informed consent in his language or a language it can understand, and sometimes a translator if needed. It's quite a burden today, but it's doable. So it's important for the patients to understand that clinical research in one country is open, in fact, to all European patients. There are different toxicities here. I was talking to the 3rd generation of ALK inhibitors. If you look at the toxicities, they are quite different. And when we select what is the best drug, we should think not only to the activity, but again, to the sequence and also the sequence of toxicity, because it will be different from one drug to another drug. There are a lot of communities now that are patients with the same disease that communicates and I know from my patients who are part of this group that in terms of symptoms and side effect management, it can be a huge help. It's also a very good way to be aware of what are the new drugs, the new trial, the new opportunity. One thing I would like also to highlight is that the drugs are given at a fixed dose. For example, alectinib is given at 600 milligrams on the morning and on the evening. But I will give this dose to any of my patients, whatever their weight, their age. Maybe it's strange to give exactly the same dose to all the patients with different bodies. And what has been shown is that when you dose the drug in the blood, it can be very different from one patient to another. And probably for some drugs, the dose in the blood matters. And one of the work we have to do is to work on the dose optimization of this drug in the patients. And there is a trial ongoing in the Netherlands called ADAPTALECT that is assessing that. I had a few other slides, but I think I have almost reached my time. So I have covered today mostly the targeted therapy. Immunotherapy is also a space where the drug development has been huge in lung cancer. In 10 years, our standard of care in patients without all these abnormalities we were talking about in their tumor, EGFR, all for the patients that don't have an oncogene addicted lung cancer, immunotherapy is now the standard of care. Over 20 years ago, chemotherapy only was the standard of care. So again, this has changed very, very fast. But I think that if there are questions, I might stop there and maybe show a few additional slides if there are questions specific to immunotherapy. Thank you.
Dr. Besse, I think it's been a super great and very comprehensive summary of all what's available now and what will come in the future. So I think the audience has been sending a lot of questions, and thank you for the information. So we have a few questions. I would just like to remind our audience that you can still send your questions through the chat and through the Q&A window, or if you would prefer to make your questions live, please make sure to press the participate button and I will unmute your microphone. So I will start with the questions, Dr. Besse. The first one is about immune checkpoint inhibitors. So the question is, how do you think immune checkpoint inhibitors change the treatment landscape for lung cancer? And are there any new biomarkers that could help predict how patients will respond to these therapies? Oh, I think you are on mute, Dr. Besse.
Okay, so maybe I will share my slide and show a few slides to explain that. As I said, when there is no oncogene addiction, immunotherapy is now standard of care. There is a very simple marker that is called PD-L1. It's an immunohistochemistry, meaning it's something you can evaluate on the tumor cells. It's very cheap, very quick. And we know that this PD-L1 staining, the intensity of PD-L1 is correlated to the benefit of immunotherapy. So a third of the patient will have a PD-L1 negative tumor, a third will have a PD-L1 intermediate tumor, and a third a highly positive PD-L1. When PD-L1 is highly positive, immunotherapy alone is probably enough, although in some patients you might choose chemoimmunotherapy. In the other ones, immunotherapy alone is not enough, and you need the combo. The PD-L1, but what you have to think, and there is an immunologist at Gustave Roussy called Laurence Zitvogel, and she's really one of the rock stars. And I'm an oncologist, and I learned what is cancer. Well, if you ask me what is a cancer, well, cancer is just a lesion that grows. This is what I learned, and I have to, decrease this lesion. And Laurence has a very different view. Laurence said, it's not a lesion that grows. It's a body that lets a lesion grow. So immunologists seeing the things in a completely different way. They said that, of course, the cancer cells divide, but the immune system let them divide, and they are not doing the job anymore. Immunotherapy is there to resuscitate the immune system. So it's something that stimulates the immune system. All the patients cannot be stimulated by immunotherapy. And this is where we have an issue. Immunotherapy was there for stage 4, so metastatic lung cancer. Now, after chemo radiotherapy in the stage 3, we use immunotherapy. And now, very recently, we can use before surgery of stage 2, chemo and immunotherapy before surgery. So I would say that if you look at the landscape, immunotherapy is pretty there everywhere. Of course, I'm talking about this cancer without an oncogene addiction, without EGFR, without ALK. The more you have PD-L1, the better is the response. On the left side is the response rate. So you see the shrinkage, the higher you have PD-L1, but still you have high PD-L1 tumors that will not respond, and you have negative tumors that will respond. So yes, we need additional markers to identify patients. Well, it's a staining that you do. I like very much the image. What is the image? It's pembrolizumab, so a drug that is a drug against PD-1. It's an immunotherapy. But on pembrolizumab, we put what we call a radiolabel that helps us to locate through a PET scan where pembrolizumab goes. So in this image, in fact, you find here, well, this is the aorta, this is the lung in black, and here in yellow, you have the lung tumor. But the more yellow you have, the more pembrolizumab you have. And pembrolizumab goes on the cells that express PD-1. It means that in this region of the cancer, you will have a lot of PD-L1. In this region, not so much. In this metastasis, muscular metastasis, you have a lot of PD-L1. So if the biopsy is done there, I will find a lot of PD-L1. But if the biopsy is done there, I will find not so many PD-L1. So you see that this huge heterogeneity, PD-L1 staining might be different in the different part of the tumor. So it's a good biomarker because it's easy to do and it's cheap. It helps us to enrich a population that benefit chemotherapy, but it's not enough. Does artificial intelligence will help? This is something we are doing with Dr. Aldea. In fact, we are collecting just the slides, the pathological slides, so just the biopsy, and we process the biopsy within artificial intelligence, and the outcome is this patient has responded to immunotherapy, this patient has not responded. Can intelligence artificial, just reading the slide of the cancer, be able to tell me, yes, this is a patient that will respond? We don't know exactly how and in which pattern, but that could be a very helpful tool. There are a lot of tools developed to try to identify the good patients, but this is, I think, something that is very promising. I will stop after this last slide, where this is something we do at Gustave Roussy. I like this a lot. With Professor Nathalie Chaput, she has a very simple tool. She can take some blood of the patients, and she said, what is the immune age of the patients. She tells there are young patients with old immune system and elderly patients with young immune system. This is what we call the immune senescence. And in fact, what we have seen is that when there is a patient with immune senescence, and this is not correlated with age, when the patients have an immune senescence, is not able to respond to immunotherapy, which is, I mean, obvious. When you give an immunotherapy, you stimulate the immune system. So obviously, you should have you need to have let's say competent non-senescent immune system. So interesting, because why the systems are senescence? Can we develop drugs that can reverse this senescence? I think it's open also a very interesting field.
That was really, I mean, I think this is probably the best explanation about immunotherapy as they have got since I'm involved in lung cancer. I think I'm not the only one because I'm reading the chat, and I also have to say that probably there is not just one rock star in Gustave Roussy after this webinar, because it all seems to be super. Yeah, and well, there's one person asking about the slides. Well, just to let everyone know that this will be recorded, that the webinar is being recorded, so you will be able to review the slides in a couple of days. When it's in our YouTube channel, you will receive an email with the link to access. And yeah, there are a few more questions in here. A lot of people thanking for the very clear explanation. The next one that I have is about inhibitor for ALK mutation. So a person is asking what comes after this third generation of inhibitors for ALK. Where are we with this fourth generation medication, if there is something? And also the question is there a realistic perspective for vaccination against ALK positive cancer or other innovative therapies?
There is still a very active drug development in ALK. The EGFR story is that we had the first generation, and at the time of resistance, 16% of the patients had one resistance mutation, always the same, T790M. And then the third generation, osimertinib, was designed to inhibit this resistance mutation. ALK, it's a bit the same. We have one main resistance mutation called G1220R. This is a resistance mutation to the first and second generation inhibitor. Lorlatinib, the third generation, is able to inhibit this. After lorlatinib, when you look at the mechanism of resistance, it's very, very diverse. You can have two ALK resistance mutation, you can have WALK resistance mutation plus MET, you can have a lot of things. And when it's so diverse, it means that it's difficult to build one drug for all these resistance patterns. There are drugs that are here. Let's see, are there, like I was talking about NVL 655, is it a fourth generation inhibitor? Is it just a third generation like lorlatinib? It's really too soon to know. The drug is still in clinical trials. Is there a hope for vaccination? Well, I hope so. Not sure. There is ALK is not only in lung cancer. There is a very aggressive lymphoma that is ALK positive, mostly in children. And these children respond also to the ALK inhibitors. And discussing, and this is what is very exciting, working in an environment where you have very different type of oncologists, and discussing with this pediatrician treating this ALK positive lymphoma, they told me, well, in my patients, one of the most important prognostic factor is if I find an ALK antibody in my young patients, meaning if these children are able to generate anti-ALK antibody, and if you find them in their blood, you know that the control of the disease will be much better. That is something, well, is there a sign that the immune system can be activated against ALK? But it's not the same disease. It's a lymphoma. And you know, lymphoma is part of the immune system. Well, it's come from the nodes, let's say, and it's part of the immune system. So maybe it's completely different disease, and we cannot do parallelism. So obviously we did well. Let's try it, and we selected with Dr. Parisi 60 patients, ALK positive patients. We had the blood already there. We tested and we find antibodies in only one patient. And we look at if this patient has very is it an outlier with a very long control of the disease? Not at all. So it doesn't prevent anything, and it is just saying that this is something we explore. Vaccines, I have a few slides on vaccine if you want in general, but we don't know yet. It's been more than 20 years that we develop vaccines. COVID vaccine have pushed very much the development of RNA vaccine. There are a lot of RNA vaccine that are currently tested in clinical trials. There are very nice early results in cancer where we don't have so much to do, like pancreas cancer, for example. But it's so much early data that I don't want to be too positive and say, well, there might be a signal. It might be one piece of the puzzle, but again, to respond to a vaccine, you need to have a competent immune system. If your immune system is senescent, it's very likely that it will not be able to generate a response to the vaccine. So probably something very complex, but I hope that at one point we will have a vaccine or cellular therapies in the ALK field, and I would say in the lung field in general.
Yeah, that's something that sounds promising. I mean, there's been something around, but it's still in a very infant stage, like using CAR T therapies in some solid tumors. So we're seeing how this could develop in the future. But I think it's probably something that we will witness how it works in the upcoming years. So absolutely, thank you so much. So in order to give response to all the questions that I'm receiving, I'm trying to merge some of them. So the next one is around something that you took base, which is around ctDNA and the role of probably liquid biopsy. So the question, I have merged two of the questions. Could you elaborate on the latest advancements in using circulating tumor DNA for minimal residual disease detection and monitoring in lung cancer? Specifically, how are these techniques improving the early identification of recurrence and guiding treatment decisions? And then the other questions related is how liquid biopsies are sensitive regarding the diagnostic capability as tissue biopsies. But if you want, yeah.
Okay. So far, what we use liquid biopsy mostly as a surrogate for tissue biopsy. So there is a patient with metastatic cancer. I want to know if there is genes mutated, and I use liquid biopsy because it's fast and sometimes the analysis fail on the tissue. For that, it's approved and reliable. But it's not for make a diagnosis. I will still have to take some of the tissue, analyze the cells, and so far it's only a pathologist that reads the biopsy that will tell me diagnosis of cancer. I cannot make a diagnosis of cancer based on a liquid biopsy today. Maybe it will be good for screening. Maybe we will not do CT scan, but liquid biopsy in the future, I don't know. There are studies ongoing, but maybe it's too soon. Technology is evolving very fast. Minimal residual disease is a very old concept in oncology. I will give you a very simple example. Prostate cancer. Prostate cancer, you have a very specific marker, circulating marker called PSA. So a patient with that has a prostate cancer and undergo surgery, what you do after surgery? You do a PSA. And I think it's like a day. It has to be negative. If it's still positive, you still have some disease in there, and then you can sometimes do additional radiotherapy, for example, when the patient is then with a negative PSA, you don't do CT scan, anything. You just do PSA, PSA, PSA. If it rises, that might be a recurrence. If it rises again and again and fast, that is certainly a recurrence, and I will do a bone scan or a PSMA a scan. And then, in fact, the management is based on PSA, and I will treat the patient and follow if the PSA decrease. I will not follow that on an image, on a CT scan. And in fact, what is minimal residual disease? It's exactly the same, but for any kind of cancer. It's really like a kind of PSA for lung cancer. So yes, I hope that at what point we will have this minimal residual disease helping us to tell you, yes, you had a surgery, no minimal residual disease, your possibility to be cured is much higher. Still, some patients will recur, like prostate cancer. Negative PSA post-surgery, some patients will recur. It's not perfect. And then maybe we will be able to detect recurrence based on that. But to be sure, we will need studies that establish that it's better to do a minimal residual disease test than a CT scan. Some of my friends in the US already use some of these tests, and they tell me, well, it's complicated because I have a patient that did this minimal residual disease test, which is, by the way, very, very expensive, and the test came back positive. And then the patient was scared. I'm relapsing. PET scan, brain MRI, CT scan, everything was negative. But still, he had the test positive in his head. And then he was, I'm relapsing, I'm relapsing. He redo the test, I think 3 or 6 months after that, and the test become negative. In fact, it was a false positive. And we know it happens with PSA, there are false positive. But you know, before using this tool for my patients, I want to be sure that I give reliable information.
Thank you so much. That's super clear. I'm very conscious of time, but maybe we have time for like still a couple of questions. So one of them is related to what you mentioned about people from different countries able to access clinical trials in some others. So there is a person from Norway saying, will a patient in Norway, which is not in the European Union, be able to avail of research slope opened in other European Union countries?
It's not in EU, but it's still, there is the S2 form in Norway, and I have some patients from Norway that were able to be enrolled. Yes, so the answer is yes.
So the countries in the EFTA will be able to access us if they were on the other member states. Thank you so much.
I agree. So sorry for that. I should have said that and not only EU. You're right. You're right.
Thank you. The other one I have here is Professor Besse. How do you see comprehensive biomarker testing and the chances to see it implemented as common standard in clinical practice?
The only way is to have political action. It's only politic, because if a politic decide to refund the test, then the test is done. I mean, all the clinicians in lung cancer, we are so used to do molecular testing. So if we have access to testing, if it's refunded, not out of pocket money for the patient, we will do it. So as simple as that.
Great, then. And I will probably go with the last question, which is just to probably illustrate a little bit more what you were mentioning about the PD-L1 levels. And a person is asking, can the PD-L1 level change during the time or treatments?
Yes. Sometimes a patient has a very good response with PD-1 blockers. And after, for example, 2 years, there is one lesion that grows. You biopsy this lesion, it's a metastasis, high PD-L1 on the metastasis, and still it's growing. This is why PD-L1 is not perfect. It's enriched in responder, but it's not perfect.
Great, then. So I think as we're reaching on the time now, I have to say that it's been pretty impressive, the webinar and how you have covered all these topics. And I can see all the people in the chat. Thank you so much for the clarity of the explanation, because I know it's sometimes a very challenging and difficult to explain topic, but I think you did it great. So thank you so much on behalf of Lung Cancer Europe for your time today, Professor Besse. It's been superb.
Thank you for the invitation. Really, thank you.
Thank you. And I would like also to thank our attendees today for joining us. I really wish that for all of you it's been very fruitful. Just a few last remarks. The content of this webinar, as I said at the very beginning, has been recorded, so it will be available in our YouTube channel. So you will receive an email in case you would like to see it again. I also encourage you to stay connected to our social media channels to receive updates on the upcoming Lung Cancer Europe activities. I also take the chance to wish you all a very nice summer break now that some people are starting going on holidays and so on. And with that being said, again, Professor Besse, thank you so much for your time today. And thank you everyone for attending. I hope to see you soon in our next webinar. So have a lovely evening and see you soon.